Hello, everyone, and so great to have you with us. And thank you for joining us and finding us with a little postponement. Tonight's talk represents part of our effort to be sure we deal with safety issues in patients with rare bone disease. So this will be a very special event for us. Before I introduce our speaker, however, excuse me, I would just like to remind you that we are hard at work developing next year's agenda. And we really want to know, and you can do it when you do your CME section, and simply feel free to send Michael or myself an email or put things in the chat. What do you want for next year? What do you think that we can do better? Because this is our real opportunity to respond to your needs. So also, I want to remind you that next month, we'll be talking about the differential diagnosis of non-XLH FGF23 disorders, a real toughie, so please don't miss that event. So now it gives me great pleasure to introduce Dr. Zvi Grunwald, who is the Emeritus Chair of from Thomas Jefferson University, who is going to discuss what, for me as a surgeon, is total terror, which is trying or needing to have to operate on someone with FOP. So we're very grateful for his insights, and thank you so much for being with us tonight. You need to unmute, sir. Whoops.
So I'll start again. Excellent morning, excellent noontime, excellent evening time for all time zones and audience, appreciating your presence in this lecture. And personally, I apologize if we have to move it by 1 week. I was involved with sending the Axiom satellite to space, and I'm involved with the research over there. So thank you for this as well. My name is Zvi Grunwald. I'm a pediatrician. I'm an anesthesiologist, and I dedicated many years to the perioperative care of patients with fibrodysplasia ossificans progressiva, or as we call them, FOP. Appreciating the invitation from Dr. Totsi, thank you, and the technical support from Michael Stewart. A few of the slides that you will see are used at the courtesy of Dr. Fred Kaplan, my very good old friend to all these trip around the world. And he found the gene for the FOP disease in 2006. A colleague, a pediatric surgeon, stated there is big surgery, there is smaller surgery, but there is no small anesthesia. And the role of the anesthesiologist is very important and carries major consequences, especially when he provides anesthesia to patients with FOP. So the objective of our presentation today is to share with you the highlights of how we are planning for safe perioperative care, demonstrate how to create an environment that will assure the patient a good outcome when he goes through or she goes through the surgical experience. I'll describe new techniques and our vision to expand the care globally. FOP is exceedingly rare disease with an incidence for about 1 to 2 million. It is caused by a single mutation at the ACVR1 BMP receptor, leading practically to a metamorphosis of skeletal muscle who turn into bone. So how does it happen that a person creates under his skin or her skin a secondary skeleton? And here is what we see on a cellular level. On this slide, you can see how skeletal muscle is infiltrated by inflammatory process. Lymphocytes start to aggregate in perivascular area, and then they go beyond into an intramuscular lymphocyte infiltration, which all leads to muscle degeneration. the muscle is gone. And what we see instead is proliferation and angiogenesis. You can see polypocytes condensation and eventually endochondral ossification, formation of bone. So we see and we describe it that having the gene itself, it's almost harmless, nothing happens. So what you have may look like a teddy bear. But what happens under certain circumstances, part and part obscure, this cute teddy bear turns to a raging grizzly. The patient develops heterotopic bone formation, severe pain, and disabling disability. So our goal, try to keep the teddy bear or the grizzly bear asleep rather than seeing it raging. This is a picture of early FOP lesions. So the first sign of the disease may happen at early childhood and look like bumps. So imagine that you are parents and your 6-year-old is 6 months old or 6-year-old child suddenly show up with a bump who is painful and warm. And the worst thing that can go to your mind are correct. Is it a tumor? What's the prognosis? What kind? And so on and on. And unfortunately, we have seen cases that was misdiagnosed and the poor patient underwent chemotherapy and unfortunately, in rare cases, limb amputation or amputation and extensive surgery. Eventually, the correct prognosis is done, but it's not unusual to sometimes months or even years lag between the appearance, the misdiagnosis until they get the true genetic diagnosis of FOP. And what really saddens us, the world expert in managing the FOP cases, that in the world we still have patients that roam around suffering and they have no clue what are they suffering from. And this is part of our mission to unveil the mystery, reach out and get this patient to the medical profession. So what actually we teach our patient, when you go to the emergency, you meet a physician, highly likely that he or she, the physician, have never seen a disease named FOP. So it behooves, if you can, tell the story, tell them about FOP, educate the physician. And one of the first rules that we have is injections are forbidden for FOP patients. Injection can trigger the flare-up and trigger FOP, waking up the grizzly bear. And this slide gives you a nice demonstration of a bone formed after diphtheria, tetanus, pertussis immunization in a boy with FOP. Very impressive. However, there are a few exceptions, and we learned that needles can be administered safely to patients with FOP under the following circumstances. Submucosal dental infiltration for dental caries and other procedures. And by the way, the #1 disability then caused by FOP is dental, because as you will hear later, the movement is compromised, the jaw may be locked or the mouth closed, and the ability to brush your teeth is significantly compromised. So dental caries and infection is rampant in these patients. And we provide appropriate care, and sometimes in the operating room with under special anesthesia and special oral maxillofacial surgery. Another way of you can use needles is for subcutaneous immunization. It was important now when we have the pandemic and you need intramuscular injection, which we don't usually we recommend to our patients, but subcutaneous immunization subcutaneous is appropriate. And of course, insertion of intravenous lines. And I can attest that I've started many intravenous lines for our patient for the perioperative care without any side effect. We also learned that advanced age, when the disease is much more settled and the disability is there, you can do even nerve blocks for surgical procedures without further escalating the advanced FOP status. And here's an example. This is a 44-year-old patient suffered from life-threatening antibiotic-resistant bacterial infection and ulcers of the right lower leg and foot. She was scheduled for mid-knee amputation. So the jaw of the patient, maybe I should go one slide earlier. So the jaw of the patient was locked. She was not able to open the mouth, precluding the placement of endotracheal tube for general anesthesia. She suffered from advanced kyphoscoliosis and limited chest wall movement, creating thoracic insufficiency syndrome that could prevent successful extubation of the trachea if she might have surgery under endotracheal intubation. We assembled a multidisciplinary team of experts to care for the patient, which is a critical care, and you will hear me repeating it again. Assembling a team is a critical step for this patient. So you can see that the anesthesiologist performed ultrasound-guided femoral and ultrasound-guided sciatic nerve blocks, which provided excellent analgesia for the lower extremity. The surgery was performed under minimal sedation only, and we published the case in August 2020. So the true challenge is managing the airway. With very few exceptions, surgical and interventional procedures should be performed under general anesthesia, and the airway need to be secured with nasal fiber optic intubation. Performing direct laryngoscopy in a patient who can open the mouth, which, wow, it's a dream. We found the hard way that it's not the way to approach. In a nearby neighborhood, a 12-year-old patient with FOP was riding her bike years ago. She fell, hit with the head the curb, developed epidural hematoma, rushed to the hospital. The anesthesiologist did the right thing that he thought. Emergently intubated the trachea. The talented neurosurgeon evacuated the hematoma, and a couple of days later, this young girl left home. 3 months later, we found out that the jaw locked for life because direct laryngoscopy stimulated bone formation and kilosing of the temporomandibular joint for life. So, take away lesson, direct laryngoscopy is not recommended, and all patient needs to have anesthesia by nasal fiber optic intubation. So the patient may have trivial surgery, colonoscopy. Most of us, at least my age, we went to the colonoscopy, brief procedure done an outpatient procedure, mild sedation. We're afraid that mild sedation sometimes can turn to an apnea induced by our pharmacokinetics and pharmacodynamic drugs. What do you do there? Under emergency situation, when the oxygenation going down, the jaw is locked, or the anesthesiologist cannot do direct laryngoscopy for various reasons. So we eliminate this, and in a case of colonoscopy, the anesthesia time may be longer than the procedure. However, the patient walks home safely and can move on with his or her life. Here are my 10 commandments for the anesthesiologist. Things to do and things not to do, things to avoid. The anesthesiologist must meet with the patient at least 1 day prior to the day of surgery. So if they come to me and my phone is available 24/7 year round for patients who need surgery or intervention procedure, and they call. What should I do? The anesthesiologist told me, I'll see you at the morning of surgery. Absolutely not. And if there is no way to change it, cancel the surgery. Because anesthesiology will have first-hand chance to see what's the limitation, what's the physiology of the respiration, how good or bad is oxygenation, and then we can plan the safe anesthesia, especially knowing that he should do nasal fiber optic intubation. And we're trying our team to reach to every single patient with FOP that needs surgery around the globe. Challenging, but it's our challenge. We know, and we can teach how to do it safely. The anesthesiologist should not rush during the induction time, avoid direct laryngoscopy, as I mentioned, and when the patient is on the operating room table, unconscious, pay special attention, protecting the patient, and I'll show some pictures and you will understand more into this problem. Shouldn't do, try not to do fiber optic intubation, rush, and go and do this direct laryngoscopy. So what you see on this slide is our life philosophy to perioperative care of patients with FOP. FOP patients deserve special measures at the perioperative time. At Thomas Jefferson University Hospital, we assembled a team of experts focusing their attention on the FOP patient. For example, you can see here an ENT surgeon because we say, what can go wrong? We cannot intubate the trachea. The patient now is sedated, airway may be compromised, and we have to assure good oxygenation. So the ENT surgeon role is, in this dire situation, establish an artificial airway by doing a tracheostomy. Knock on wood, I have the best real wood. We've never been there, but we have to be prepared. And you can see other experts that are participating in the care of this patient at our team. The nursing team is very important, and they actually following the patient journey from the holding area to the operating room, recovery room, critical care unit there is need, and to the floor. In my rounds before surgery into the operating room, I can see that the nurse, and usually they know that I'm trying to check the things ahead of time. Dr. Grunwald, here's a tracheostomy kit ready to go. And as you can see on the paperwork dictating this is surgery for whatever procedure is, airway should be prepared, the kit should be ready, and it shows that we actually have a system that gears to manage FOP cases, patients at all levels. So we involve, as I mentioned, the specialties early on, and we prepare the hospital to become FOP friendly throughout the course of the patient, especially when we bring a child with FOP to the perioperative area, holding area, operating room, recovery, and beyond. And as you can see here, the note important showing up along the lecture, talking about creating a team. And usually what we do, we bring the patient, the caregiver, the family, all the medical expertise that related to this procedure, we call them the FOP experts, and we talk about the procedure. And we walk ourselves and the patient and the family step by step, what I have to do, what are my challenges, what my expectation from myself, from team members, and everybody speaks up. That brings really team effort and assure that we can tell the patient, we'll see you in the operating room and you will go home safely after the procedure. Undergoing a surgical procedure is a major event in everybody's life, especially in the life of a patient with FOP. I tell them it is your day in the Olympics. And like you see the champions preparing all their life, and especially before the Olympics, you should have the best training. And we call it not rehabilitation after surgery, but prehabilitation, which is dedicated mostly to make the respiratory system stronger and fit. And the goal to bring them to the OR at the best physical, emotional, and spiritual shape in order to optimize a great outcome. As you can see, we tilt the operating room trying to fit the shape of the person, because this patient, because of the disability and the muscle who turn bone, are fixed in different positions, bizarre positions sometimes, but that's the daily life reality. As the head, as you can see, may be far away from the OR table. So we have to put blankets, gel pads, padding, and on for every specific case. In monitoring, we require for most patients routine monitoring, EKG, non-invasive blood pressure, pulse oximetry, end-tidal CO2, and of course, temperature. If the patient has significant comorbidities, lengthy surgical procedure, or a compromised cardiovascular system, we may require different or additional monitoring. Here's a typical position of the operating table for dental procedure. So the dental team, the dentist or the oral maxillofacial surgeon can reach the oral area. However, this position may cause significant discomfort and may result in further respiratory compromise. At more advanced stages of the patients, because of the respiratory compromise, they may suffer from hypoventilation, hypercarbia, and increased pulmonary vascular resistance, leading to heart failure. And when you tilt the table, it will further compromise the delicate physiology of the patient. And patients who were coming for repeated procedure, mostly dental, we could tell that from time to time, as they age with the disease, we have to keep the table less tilted, which we call it Trendelenburg position, in order to accommodate for the changing physiology of the patient. I usually leave part of the patient extremity exposed so I can monitor visually the quality of oxygenation and circulation independent for our fancy electronic monitoring. We pay special attention, as I mentioned, protecting the body, and you can see here the various steps so the patient may not slide out of the operating table. And you can see here, patient is asleep, the hand actually fixed in this position, but we add extra foam just to make sure that, as you can see, the extremities are optimally positioned. We encourage our young patients to bring a friend to the operating room, and the friend is usually waiting for them when they wake up. Here's a publication. We published 30 patients undergoing 42 surgical procedures for dental procedure in the literature. And I believe that it will be rarely, if ever, replicated, having 30 patients, which actually needs to a population of over 60 million to feed into, and they're coming for different places, states, countries, and continents. So what we have learned from our cases, published by Dr. Kimmel in 2014, that you can see almost more of the half of the patient were at pediatric age. 80% of the patient was discharged from the hospital on the same day of surgery. One of the reasons we conducted the study, because in a preliminary literature search, we noticed that many patients stay in a hospital days on end, why they should actually go home. A dental procedure, patient may stay in a hospital 4 or 5 days, unnecessary. So what we are showing here, that actually, if you do the anesthetic right, with the right team, with the right protective environment, patient may go home. And we know the less you stay in a hospital, it's better for your outcome. 14% of the patients actually, 14% of the patients were kept one night to monitor for comorbidities like asthma and diabetes. And as you can see at the bottom, it's important to notice that all of our patients had smooth perioperative course without any significant adverse event. They actually did very well. To date, we have performed almost 150 surgical and interventional procedures for patients with FOP with excellent results. So as you can see here, at Thomas Jefferson University, we actually built a multidisciplinary center which is open every day, year-round. We provide medical expertise and counseling and consultation, even for non-medical issues. We have cared for patients with FOP throughout their lifespan, and they are arriving from 5 continents to our team. My personal hope, and that's what I'm trying to accomplish, is actually to build a one center of excellence at least in each continent, so you don't have to drag at extreme cost and inconvenience to our center of excellence at Jefferson. And we are reaching there. At Europe, there are a few centers I established with a local pediatrician at the Children's Hospital in South Africa, in Cape Town. One is center, and actually with 1 billion patients in Africa, and we have a single place in South Africa, but we hope to expand it, and we go from there to other places around the globe. Here's an example of patient in Israel. Our team traveled to Israel for a dental procedure, 26-year-old individual, computer engineer. You can see the parents, procedure is done, and here is our excellent anesthesiologist, Dr. Matou. Here you can see that we moving the needle further. With few cases that young individuals, usually with milder variants of the disease, young individuals, they want to become moms. They want to become pregnant. It deserves a very serious discussion because, as you know, pregnancy is challenging. What do you do if it's 4 a.m. in the morning and you may be living not in a central city area, you develop bleeding. You may need a surgical procedure. Urgently, can we guarantee that you will need an expert anesthesiologist who can safely perform nasal fiber optic intubation? However, we met our team, as I said, with Dr. Kaplan, we are traveling across the globe. So we met a young individual in England, and she wanted to become mother. Half a year ago, she delivered safely under C-section, under general anesthesia with nasal fiber optic intubation, a healthy male boy, and now she's the mother of a half-year-old baby. In southern US, in one single center, medical center, we have 3 mothers holding babies. And now we're having at Jefferson another young individual who is in a process trying to become pregnant and eventually go through successfully and become a happy mother to a happy baby and establishing a happy family. Other things that actually happen is that we managing pain for this patient in new modalities, and we now allow surgical interventions to happen without creating further disability, like thoracocentesis, chest tube insertion, even extensive physical therapy to improve respiratory function. The next point here is actually using 3D printing to guide our treatment. So I'll share with you two clinical cases, but before we move further to the presentation, we will actually pause here and we will have a moment for announcement and Q&A.